Survey Puri. She is a senior resident in Community Medicine Department in AIMS, Delhi, India.
Good evening, everyone. I'll be discussing about the guidelines for primary prevention of cardiovascular diseases and CVD risk assessment tools. So, as we know that cardiovascular diseases are the leading cause of death globally, with affecting around a proportion of 1/3 of the total deaths worldwide and around 27.1% of deaths in India. CVD develops due to accumulation of damage by an increase in the duration or number of risk factors in individuals. It is also, there is known to be a multiplicative action of the presence of risk factors. That is, the presence of more than one risk factor leads to a multiplicative effect that the sum of their individual risk is less than the risk of a combination of presence of more than two risk factors. Then identification and early interventions to reduce damage are crucial for the prevention of NCDs. So this shows that basically there exists a continuum from the presence of risk factors to development of cardiovascular diseases. There exist non-modified risk factors like age, sex, ethnicity, family history. There is presence of underlying determinants in the population that are globalization, urbanization, population aging, and social determinants. These further lead to changes in lifestyle, leading to lifestyle risk factors that are unhealthy diet, tobacco smoking, harmful use of alcohol, physical inactivity, and air pollution. These lifestyle risk factors further lead on to metabolic risk factors that are raised blood pressure, raised blood glucose, raised blood cholesterol, obesity or overweight, abnormal lung function, and they further lead to cardiovascular diseases. So for guidelines of primary prevention of CVDs, I would mainly be talking about three guidelines. That firstly, it is the American College of Cardiology and American Heart Association 2019 guidelines for primary prevention of CVDs. Second would be the WHO guidelines. Third would be our national guidelines and the program for prevention of cardiovascular diseases. So firstly, under the AHA guidelines, it gave the concept of a patient-centered approach. They conducted a thorough review of literature and found out that multidisciplinary team-based care had better outcomes to prevent CVD cardiovascular outcomes in patients. So basically, what is a multidisciplinary team? Multidisciplinary team can be like a primary care physician for identification of risk factors, diagnosis of diabetes, hypertension in the population, and then maybe there would be an endocrinologist that would review the blood glucose and keep the control of diabetes in the individual. Then there would be a dietitian that looks after the dietary modification in the patient, and then there might be a psychiatrist that might be that would have a role in tobacco cessation in people who utilize tobacco. So then the second was shared decision making. Shared decision making, what it includes is that the decision making of the management should be there should be a two-way approach. That is, the patient and the doctor should both agree on the management. So you should give them an option of the management strategies that are there, and they can adopt according to what suits them best. For example, if you want to modify their lifestyle, you want to increase their physical activity, so you suggest them brisk walking, but they might not have a park nearby their home. So you have to improvise, and they might be agreeing to do yoga instead. So that would be shared decision making. Similarly, for prescribing medications might have some side effects. So they might be willing to, for example, with diuretics, it might lead to increase in urination. So you have to give that option to the patient if they would be agreeing with that prescription or not. Then addressing social determinants. Social determinants are crucial to ensure compliance to our management, both lifestyle management as well as the therapeutic management. So that is important to address. For example, the socioeconomic status of the patient, the advices that we give. For example, dietary advices that should be corresponding to the socio-economic capacity of the patient, and maybe we are advising physical activity, as we discussed that they might not have a park nearby. So maybe enabling environment, presence of enabling environment should be important to discuss while giving this management. Then cardiovascular risk assessment. It also talked about cardiovascular risk assessment with the use of 10-year risk prediction charts. The risk prediction scores, which uses a full cohort equation. This is for the age group of 40 to 75 years. For young individuals, it suggests individual risk factor assessment at every 4 to 6 years. Then for dietary recommendations, AHA recommended plant-based diet, which will increase fruit, nut, vegetable, legume, green vegetable or animal protein, preferably fish intake. Reduce saturated fats and sodium consumption to less than 2 grams per day. Minimize intake of processed meat, refined carbohydrates and sweetened beverages. Recommended physical activity was 150 minutes per week of moderate intensity or 75 minutes per week of vigorous intensity. Then for raised blood glucose, after the diagnosis of raised HbA1c, we can advise dietary counseling regarding key aspects of our healthy diet, at least 150 minutes per week of moderate to vigorous physical activity, then aggressive treatment of other CVD risk factors, consideration of metformin as a first-line pharmacological therapy to improve glycemic control and reduce CVD risk. If HbA1c is less than 7 after lifestyle therapies and metformin, then reinforce the importance of the same and continue the same management. But if it is not controlled, then does the patient have other CVD risk factors? If there is presence of other CVD risk factors, we might consider adding SGLT2 inhibitors or GLP-1 agonists to improve glycemic control and reduce the CVD risk. Then next would be raised serum cholesterol. For raised serum cholesterol, we divide it into 0 to 90 each group, where lifestyle to prevent or reduce CVD scores can be suggested, and if familial hypercholesterolemia is there, then statins can be given. For the age group of 20 to 39 years, lifetime risk is estimated, and if statins should be considered if family history of premature CVD risk and LDL cholesterol more than 160 is present. For the age group of 40 to 75 years, if LDL cholesterol is between 70 to 190 mg per deciliter without the presence of diabetes, a 10-year CVD risk person begins this discussion. So, in this, if a low risk is present, that is less than 5%, then emphasize on the lifestyle modifications to reduce risk factors. In a borderline risk discussion should be there if risk enhancers are present, like presence of renal failure or other risk factors, risk enhancers, then moderate statin therapy can be considered. For intermediate risk, if risk estimate plus risk enhancers favor statin, then initiate moderate intensity statin to reduce LDL cholesterol by 30 to 49%. For high risk, that is more than equal to 20% of risk, then this discussion should initiate statin to reduce LDL cholesterol more than equal to 50%. Similarly, if the LDL cholesterol comes out to be more than 190, then no risk assessment needed to be done, and high intensity statins should be given. Diabetes mellitus and age 40 to 75 years and moderate intensity statins can be started. Diabetes mellitus in age 40 to 75 years, risk assessment to consider high intensity statins should be done. Then for raised blood glucose, if 3P is normal, then promote optimal lifestyle habits. If there is elevated blood pressure, 120 to 129, pre-hypertension blood pressure, then non-communicable therapy can be given. Stage 1 hypertension, 130 to 139 and 80 to 89. Then we have to estimate 10-year CVD risk score of more than equal to 10%. If it is more than equal to 10%, then non-pharmacological therapy and BP lowering medication should also be started. For stage 2 hypertension, you can straight away start BP lowering medication along with non-pharmacological therapy. Then tobacco cessation should be stressed upon. We can also consider giving low-dose aspirin, that is 75 to 100 mg orally daily, between the age group of 40 to 75 years with high-risk CVD score and with no risk of bleeding. Then coming to WHO guidelines for primary prevention of CVD, WHO gave a package of interventions to prevent CVD, that is the WHO HEARTS package. This can also be applicable to low resource settings. So what consists in the HEARTS packages? H for healthy lifestyle counseling, E for evidence-based treatment protocols, A for access to essential medicines and technology, then R is risk-based CVD management with the use of WHO CVD risk charts, then T for team-based care, similar to the one we discussed in AHA guidelines, and S is for systems for monitoring. Then coming to our national guidelines, we have a national program for national prevention and control of cancer, diabetes, cardiovascular diseases and stroke. Under this program for primary prevention of CVDs, there is scope for health promotion to promote healthy lifestyle, then opportunistic screening of risk factors. All the patients coming to the OPDs, they suggest that they should be screened for presence of risk factors. Then camps should be held in high-risk groups, and periodic camps should be held to screen for the presence of these risk factors. They have also started something called population-based screening. That is, they line list all the population in the area above the age group of 30 years. This is done by ASHA. Then all of this population is screened for blood pressure, blood glucose, family history of CVD, tobacco consumption, or alcohol consumption. And any of these found to be screen positive can be further referred to PHCs for management, and in case they require expert management, then they can be referred further. Coming to the risk assessment tools, what is the role of risk assessment tools? Basically, they guide risk communication. It makes it objective or easier when a patient comes with presence of these risk factors, that we can objectively give them a number so that they can understand the importance or the risk that they will undergo if they do not work towards it and do not adopt healthier lifestyle. Secondly, helps in prioritization of interventions in low resource settings. For example, in India, in low resource setting, we have to prioritize our resources accordingly. The cost estimates that are available for management of cardiovascular diseases would not suffice the amount of burden that we have. So we have to have a plan for prioritization of those most in need. Then thirdly, they would also guide clinical decision making by risk classification. As we saw in the previous risk assessment, they classify according to risk that a person has to develop cardiovascular diseases. So interventions can be started accordingly. For example, when we see these charts, after 20% of risk according to these charts, you have to start statin therapy. Various CVD risk assessment tools that are available are Framingham Risk Score table chart, Australian CVD Risk Assessment chart, Joint British Society Cardiovascular Disease Risk Prediction chart, New Zealand Risk Assessment chart, the Q-Risk2 calculator, S-Risk calculator, WHO CVD Risk Prediction charts. These are the ones that can be easily used even at the peripheral levels. So this can be easily applied to our model of low resource settings. Then in young adults, the problem with most of CVD risk assessment tools are that they start assessing risk or predicting risk in a population above the age of 40 years. But the presence of these risk factors and lifestyle related risk factors starts very early, and they have to be identified early so that the progression can be stopped as early as possible. So for young adults, there are fewer options available, and the predictability of these options are less as compared to the ones in adults. The ones available are 10-year and 30-year Framingham Risk Score, Atherosclerotic CVD Risk Calculator, Pathobiological Determinants of Atherosclerosis in Youth Risk Score, Coronary Risk Score, Risk Score, AHA Ideal Cardiovascular Health Metrics, Progeto-Curo Equation, Framingham CHD Prediction Score Tool, Heart Score, Framingham Risk Equation, and System Coronary Risk Evaluation, that is the score. So one of them that was recommended by the ASCVD guidelines was Atherosclerotic CVD Risk Calculator using pooled cohort equation. So the variables that are put into this equation are the sex of the patient, then age of the patient, which can range from 20 to 79 years, race of the patient, total cholesterol, HDL cholesterol, systolic blood pressure, history of diabetes, smoking, and history of treatment of hypertension, whether the patient is currently on treatment for hypertension or not. So according to this, 0 to 5% is a low risk, 5 to 7.5 is a borderline risk, 7.5 to 20 intermediate risk, and more than 20 is high risk. For a borderline risk or intermediate risk, we can also use something that is called coronary artery calcification measurement. So coronary arteries, since these are the ones that are, there is no, these come in between the gradation of risk So low risk, you would just have to do lifestyle modification. High risk, you would have to start therapy. But the intermediate risk, the decision has to be made whether the drug therapy has to be started or not to be started. So one of the things that can be used for that to guide that decision making is coronary artery calcification measurement. So if it is 0, then below threshold for statin benefit, consider avoiding or postponing drug therapy. For calcification 1 to 99 AU and less than 75th percentile, subclinical atherosclerosis statin risk estimate is similar. You can repeat the clinician-patient discussion with new information and can consider statin therapy now or postpone it to after repeating CHC in 5 years. But if it is more than 100, then you have to start drug therapy as soon as possible. Then WHO CVD Risk Prediction charts. These are part of the WHO HEARTS package. These are in the age group of more than 40 years. There are two types of WHO risk prediction charts that were released in 2019. They were firstly the laboratory-based charts, secondly the non-laboratory-based charts. So the advantage of these WHO risk prediction charts comes in the non-laboratory-based charts that are so simple and easy to use that they can even be used at sub-center or primary health center levels. They do not require any blood collection or any investigation to be done. Laboratory-based, the variables used are age, sex, smoking, systolic blood pressure, presence or absence of diabetes, total cholesterol. Then for non-laboratory based, we use age, sex, smoking status, systolic blood pressure, BMI, and these are color-coded and easy to interpret, and non-laboratory based, as we discussed, can be used at peripheral levels. So the gradation goes as green is low risk, that is less than 5%, then there is yellow, 5 to 10%. Then there is orange 10 to 20%, red 20 to 30, and deep red more than 30. So basically what happens is these are the risk prediction charts. So first step in a laboratory-based chart is to select the section of the chart for people with or without diabetes. All of these charts exist separately for different ethnic groups. So for Asia, Southeast Asia, we have different charts for Southeast Asia population. So first step is to select the section of the chart of people with or without diabetes. Then select the table for men or women as appropriate. Then select the column for non-smoker or smoker. And then select the relevant group. So as we can see, age can be seen on this axis. We have total cholesterol on this axis and SBP on this axis. So after we select the age and the gender, this side is male. And this side, these two blocks are female, these two columns are female. So we have to just plot the same and see where our risk comes, and that number can be taken as a percentage of risk. That is 10-year percentage of risk of developing a CVD outcome. So how do we guide clinical management is risk less than 10%, then you have to just counsel on diet, physical activity, smoking cessation, avoiding harmful use of alcohol. If it is less than 5%, follow up in 12 months, 5 to 10%, follow up every 3 months, then 6 to 9 months thereafter. Then 10 to 20% of risk, counsel on diet, physical activity, smoking cessation, avoiding harmful use of alcohol, persistent BP more than equal to 140/90, consider drugs. Follow up every 3 to 6 months. For a risk of more than 20%, along with the ones done above, firstly we have to keep the cutoff for BP of 130/80 and have to consider drugs for a BP value above that. Secondly, we also have to start a statin therapy. So the take-home messages from the presentation would be cardiovascular diseases are a leading cause of death worldwide. Primary prevention is crucial to address the high burden, especially in low-resource settings. Patient-centered approach consisting of a multidisciplinary team-based care, shared decision-making and addressing the social determinants in the population would be crucial. Health promotion can be done by diet, physical activity, tobacco cessation and reducing the alcohol consumption. Use of risk prediction charts can be done for risk communication, prioritization of resources and risk-based CVD management. Thank you.